Good morning. It's the 10th of March, and we're going to get ready to open Division 3 work session on Division of Long-Term Supports and Services. Just to give folks some context, today I'd like us to see if we can get through this by noon. And I realize to do that, I have to keep an obligation to only ask the essential questions. And I'd hope all the committee members keep in mind we want to be able to wrap up at noon. And then tomorrow is an interesting day for us. We'll be looking at the Veterans Home and other direct care providers, the New Hampshire Hospital, Glencliff Home, Hampstead Hospital. So that's tomorrow. And then I think we've squeezed in the Prescription Drug Affordability Board. I can't really tell what day that is. That's a Wednesday. Okay, and then Thursday we have session. And Representative Wallner, you asked me if we had anything on the 14th. And there's nothing on the calendar, and we talked through it in a working group this morning, and I don't think we need to schedule anything on the 14th. So, but we are going to have to add something on the 17th. On the 17th, I've asked Mr. Ripple to anticipate the new bills that we're going to get as a division, and I want to schedule the 17th for us to hit the bills. So that's where we are overall. And welcome, Dr. Hardy. No, not yet.
No, not yet. No.
Yeah, Ms. Hardy and Mr. White, and we're looking forward to your presentation.
Great. Good morning, Nathan White, Chief Financial Officer with the Department of Health and Human Services. Today in the governor's operating budget, we'll be working from pages 893 through 907. And then we will also be working from pages 1014 through 1025 for the DD budget. In front of you, you also have the budget briefing book. Again, just as a reminder, it's for accounts over $1 million annually. And with that said, I will hand it over to Melissa.
Thank you, Nathan. I'm Melissa Hardy. I'm the Division Director for Long-Term Supports and Services. So thank you for having us this morning. I think in the interest of time, I know there's a lot of slides there. So Chairman Edwards, if you're okay with me kind of accelerating a little bit.
We're in your hands.
Okay. So I think probably starting on slide 3 to just give a quick overview of the division and the people that we serve. Our division has 3 distinct bureaus: the Bureau of Adult and Aging Services. We have the Bureau of Developmental Services and the Bureau of Family-Centered Services. One thing I'd like to point out that's unique with us is that we serve people throughout the lifespan. So our Bureau of Family-Centered Services serves kids from birth to up to age 21. And then we have our Adult and Aging Services and our DD services that serve adults and people with physical disabilities. So in talking with our stakeholders, we could have a parent who's taking care of somebody on the DD waiver who also receives CFI waiver services at the same time. So we overlap in a lot of different ways, but have the honor of serving people throughout their lifespan if needed.
So from a budget context, a BDS is probably what? For general funds, probably 60% of your total budget, just approximately. It's the elephant in the room, right?
For BDS, it's yes, I would say it's significantly higher than our other divisions.
And then aging and adult relative to family-centered, are they effectively the same or?
No, I would say family-centered service is less than adult and aging services for general funds. Yes.
All right. I find that kind of context useful. So thank you.
Sure. Slide 4 is just, again, a brief overview of what we do at the division, providing guidance and technical support and quality monitoring for our provider networks on all 3 of our bureaus. So we're there as a resource. We do a lot of contracted provider work. Giving them the time and the technical assistance in order to make sure that we're following our rules of engagement with our funders and making sure that we're reporting out on a timely basis. We also work with Meredith Toulouse's group, the Division of Program Quality and Integrity, when we do things like service file reviews, we do redesignation reviews, and partner with her team to look at those outcomes and quality measures. Slide 5 is just a brief, a high-level look of our org chart. For your context. So again, just shows the 3 different bureaus. We have a chief operating officer of the division. They're all here with me today, so if I need to phone a friend, they're here to answer questions that I can't, so happy to have them here with us. Slide 6 is our staffing and vacancy rates. So you can see we're pretty proud of our vacancy rate being at 4% for the Bureau of Adult and Aging Services, 15% for developmental services, and 6% for family-centered services.
So 15% relative to workforce shortages around the state, 15% seems to be a pretty relatively low vacancy rate. I'm still a little bit curious. What do you think the single biggest or a couple biggest reasons for you having a vacancy rate in BDS?
I think we've spent a lot of time fostering a positive work environment for people to want to work in, and then seeing the results of the work and talking and engaging with families and providers. I think that gives a lot of context to, why people stay in their jobs. It's not necessarily for the glory, it's for, seeing outcomes for the people that we serve.
What I should have said it a little different. What do you have a barrier to getting closer to a 4 or 5% vacancy rate? What's sort of in the way?
Yeah, I think because of the number, we only have 27 authorized positions. So when you have, 4 that are vacant, it really, skews that number. So I think right now we have 4 vacant positions in BDS.
Okay.
So when you look at that, I just think the end number is low to begin with.
Thank you.
During the governor's budget, we were unfunded 8 positions in the division. So 3 in the Bureau of Adult and Aging Services and 5 in BDS, the developmental services.
Okay.
Slide 7 is really just a visual of our department and the different ways that we help across the division with our areas. So family support, we have adult protective services in our division. We provide early intervention services for kids and families, information referral, food and nutrition. So just a kind of like high level view of the different array of services that we manage throughout the division. And let me know if I'm going too fast or too slow.
Nope.
Okay.
It's hard. It would be hard for you to go too fast. Now,
Okay.
were you one of the ones that came to us in January to just give us the information portion? Okay, so a lot of this shouldn't be new to us.
Right. I think Chris Santinello presented to this
Right.
team just kind of the higher level programmatic view of our division. So
All
yes. I know you've heard a lot about the department's roadmap and our initiatives there. So we are Initiative 7 for building a system of care for healthy aging, which you've probably heard a lot about in HB2 of 2023 and the work going onwards that we're doing for that. And then Initiative 8 is strengthening the developmental disabilities program and systems. So looking at parity and rates and looking at a reimbursement system that is predictable. Slide 9. Oh, go ahead.
I'm sorry,
Yeah.
I'm a little slow. So at the bottom of slide 8 on goal 2, develop and propose a new reimbursement rate structure. Can you just give us like 4 sentences what the old and what the new?
Sure.
What are we doing there?
Yep. So we contracted with an actuary to look at the actual costs of providing our services in the DD field. Worked with them for about a year and a half, 2 years on services, and our rates hadn't been studied, I think, since 2017. So what we found was our rates were significantly lower in comparison to not only other states, but what the actual cost of doing that business is. And we link that directly to having services authorized, but not having providers to provide those services. So it's great that that everyone's funded for services, but if you can't find a provider because they don't get an adequate reimbursement rate for services, we're not going to be able to provide the service.
So is the expectation that we're going to probably increase rates overall in the aggregate and to draw out more supply? And in the process of doing that, we're going to have both an increase in quantity and an increase in the price. So our total spend at the state is likely to end up more.
It'll end up more in the short term. I think our strategy or our proposal was to focus on those services that are lower cost and keep people in the community.
Is there money in this budget for
It was a
that transition?
it was a prioritized need that we put in that was not funded.
Okay. All right. Thank you. Representative Wallner, it looked like you might have a question there. All right. Go ahead. Yeah, Representative Priest.
Thank you.
You're in the sun there. It's kind of hard
I
to see
am in
you
the
with
sun.
that
It's the
gray hair
season of the
reflecting.
sun. Yay. Thank you for taking my question. Can you give us some numbers of how many aging adults are in long-term facilities versus home care?
Yes,
And, and what are the needs and what are the unsupportive needs out there?
I can give you the numbers. So in our waiver, we have to report out unduplicated counts of people that we serve. So on the aging in adult waiver, which is the Choices for Independence or the CFI waiver, we serve about 4,161 individuals. In contrast to the nursing facility care, so it's in lieu of nursing facility care. They're averaging 3-month average for nursing facility care is about 3,688 individuals in our nursing homes. On the developmental services waiver, we serve 5,061 individuals just on the waiver. For our acquired brain disorder waiver, we serve 228 folks. And then on our in-home support waiver, which is our children's developmental disabilities waiver, we serve 488 children. I do want to say that our service delivery system certainly serves a lot more people than the people just on the waivers. So, for example, we would say on the DD side of things, we serve over 15,000 families and people in general when we're looking at all the services, not necessarily just people who are on the DD waiver.
As a follow-up, how many additional people are asking for services, but you can't provide services?
So we don't have a wait list for services, funding for services, let me say that. We don't have a funding wait list, but again, finding providers to provide the services that people need at the rates that we have, especially on the DD waiver, is hard. So we're able to fund everybody, which is great, but we're not able to provide all of the services.
Okay, thank you.
Slide 9 is just, and you can read these are just some of our accomplishments that we've had over the past 2 years for each of our bureaus. I will say one thing that is prevalent throughout all the bureaus is our investment in IT, and I'll talk a little bit about that, our infrastructure and how we've changed and are able to not only track data better, but also produce some outcomes that we weren't able to really do before because it was a manual process or it was done by an outside system that unfortunately is no longer operable. So we've spent a lot of time creating processes in New Heights that automate a lot of things for us. I can highlight some of those things as we move ahead. I do also want to say, and I'm sure a lot of people have heard, on the Bureau of Developmental Services on July 1st, 2023, we finally closed out our corrective action cap that we had with, oh yes, Representative Stringham knows all about it. We were able to close that out and meet compliance, and that was something that had been out there since 2017, I believe, that we've been working towards. So, this team and our providers and our area agencies have worked really hard to gain compliance with CMS and give us the nice letter that that cap is closed out, so we can move towards, move from compliance and CMS and, looking at those regulations every day to really how do we strengthen and make it a system that meets the needs of the people that we serve. So I just wanted to note that it's been a long process for the Bureau and the division, so I wanted to give that some time. Any questions on slide 19? 9, sorry.
So I looked ahead through 14, where you've got IT enhancements. And let me just say that I love the fact that your division specifically got into the IT issues, because this is one of my big things is, what are we doing to leverage our IT to drive productivity or to improve, reimbursements from the feds or from others. And it looks like in a lot of these are cleaning up process. But of these that have been completed or in progress, which one do you think has the biggest impact on driving productivity?
Can I have 2? Because I feel like
You can have 2.
All right. I would say the transition for our adult protective services to go into New Heights, it just creates a lot of efficiencies for our staff as it relates to case consultation notes. We're able to pull data a lot easier than we were in our old system. That's not really supported anymore. So I would say adult protection going into New Heights, but then a very close or maybe equal would be our Bureau of Developmental Services also going into New Heights, where we're able to automate a lot of functions as it relates to service authorizations. We can see where they're at in the process. Our providers can see into that system as well, so they can see if a service authorization has been submitted. Is it waiting for the department? Is it waiting for the provider? Just creating a lot of transparency so it's not something that's stuck in a spreadsheet at the bureau level, where at any point a provider can go in and look to see where their case is at. So I think those 2 would be our 2 biggest accomplishments.
Outstanding. So if I may make a request for the Oversight Committee, occasionally you talk to the Oversight Committee. One of the times coming up, would you do just a special focus on leveraging of IT?
Sure.
Okay.
Yes, I can do that.
Thank you.
You're welcome. And I do want to add a little note to the IT. I know that there's been, there's been a lot accomplished over the biennium. And I think, really looking at if we were to reduce our allocations for IT, not only this is great, right? This creation of these IT services, but we also have to make sure it's funded, going forward for maintenance, and any other updates that, will streamline our processes and make not only the lives of our staff better, but, quicker service delivery to the folks that we serve. So I just want to put a plug out there for that.
So you brought up a really big expense item,
Yes.
Maintenance. Generally, New Heights is budgeted for maintenance in these departments, Mr. White, or is that under a big catch-all in your Department of IT in the department?
I believe that's budgeted in Class 27 within the Office of the Commissioner within the Bureau of Information Services.
Okay, so at some point there may be kind of a training or a transparency thing for the members, just so that we know that New Heights, for example, is helping support specific departments, and correlating the costs with the benefit could help us. I don't think we need to worry about that in this budget cycle, but it'll be an ongoing.
Sure. I think the presentation that Dave Wieters had provided early on a number of weeks ago had a breakdown of each system, and then the benefiting or parties or services delivered to specific parties. So you may have a reference document, but we're more than happy to talk about that in the future.
All right, thank you.
So slide 16 goes into, now I'll talk about each of our bureaus and go through their accounting units. We'll start with the Bureau of Adult and Aging Services. So slide 16 just gives an overview of what we do in the Bureau of Adult and Aging Services. So just to note, we did have a bureau name change. You probably heard of us as the Bureau of Elderly and Adult Services, and in looking at age-friendly language, and we're all aging, and I have a little, I'm not wearing it now, but a little pin saying aging, everyone's doing it, right? So it's not just elderly. I think elderly, has that negative connotation and prevents some people who are aging that might, want to access preventative services that we serve, but don't consider themselves elderly. So we were able to, we enhanced our name to adult and aging to take out that kind of elderly connotation, and that we're all adults and we're all aging. So we might need services at some point. We're looking at strengthening our adult protective services, again, through the IT enhancement, but also looking at training opportunities for them. We're seeing in a couple of slides ahead, we're seeing some trends in adult protection as far as what we're seeing for cases. More cases as it relates to scams for older adults, financial exploitation, and a lot of self-neglect or isolation. So we'll talk a little bit about that. We administer under the Bureau of Adult and Aging Services our Choices for Independence 1915C Medicaid waiver. So that provides services to adults in the community who meet nursing facility level of care, but choose to have their services in the community. We also determine medical eligibility for level of care, not only for people on the Choices for Independence waiver, but also for individuals who are admitting into the nursing facilities to ensure that they meet and need that level of care medically.
So on that bullet specifically, to what extent today are the counties officially responsible for helping with the medical eligibility level of care?
The counties are not responsible at this time to be part of the process. We are working with Merrimack County, as they have doing a pilot with Merrimack County to they have some navigators in their system to see if we can transfer some of that, from their waiting list for eligibility, not only for the nursing facility, but for CFI, and have them kind of be a quasi arm of the department to help determine eligibility.
And then on the previous bullet about the waiver, so I understand the waiver, we when we asked for it and received it, we basically made some commitments, things that look like commitments of how many people we would have in CFI at each year.
Yes.
And as I understand it, we're only about 65% of those targets. What kind of potential problem would that cause with the federal government if we don't basically achieve what we said we would with the CFI?
I think we would have to give them an explanation of why we're not seeing the growth in those numbers. We've talked internally about, when we do our waiver amendment, to really look at that projection to see if that's something that is attainable in New Hampshire. Not that we're not an aging state, because we all know we are, but we also have to have enough people who are eligible for Medicaid in order to be on the waiver. So what we're seeing is our age is, the number of older adults is climbing, but the number of older adults that qualify financially for Medicaid is not climbing at that same rate.
Yeah. So what I think I heard you say is that we don't anticipate any problem with the feds. We may just have to update our waiver.
Yeah, and we would do that in our next amendment, just to say, explain why our projection isn't what, is being served, and, any interventions to help that.
Yes, Representative Seaworth.
Thank you, Mr. Chairman. Kind of as a follow-up to that, is there a connection? So if we're at 65% on what we expected to do, is there a federal grant that we have to curtail because because we're not eligible for it? Or is it all taken care of in the waiver process itself?
Yeah, I would say we're good from that side. It's taken care in the waiver. We also have, we received another federal grant outside of the CFI waiver called Money Follows the Person, which is 100% federal funds that really focus on transitioning individuals out of nursing facilities to remain in the community. So we also have that project that we're standing up and operationalizing now.
Thank you.
Yep. And then we contract in adult and aging services with providers in the community to carry out services that are funded through other funding streams. So I think what you'll see in this bureau particularly, we braid a lot of funding together. So we get funding from not only Medicaid and not only the state, but we have Older Americans Act money that we get in social service block grants, different streams that fund preventative community-based services. So you'll see it's not, I think on the other, in our other divisions, you'll see that it's 50% Medicaid, 50% state dollars. This is a little different when we're talking about the funding of things like meals and nutrition, family caregiver support, in-home care, so nursing care in somebody's home or housekeeping. So it's a breeding of multiple funding streams, not just your traditional Medicaid and state funds.
So I'm jumping to slide 19.
Yeah.
And I'm looking at the bottom, the number of sexual abuse reportings. What is there a general setting in which those seem to be more predominant? Are these settings like, private nursing homes, public nursing homes, CFI?
I don't
If
have
you
that
don't have the data,
information.
don't worry about it.
Yeah.
It's an information only question. It just makes me curious if we have
A trend.
something that we should be doing that's setting base to try to reduce that.
I'm sure we have the data. I just don't have it with me, but we can look at that to see if there's any trend or environment where we're seeing that more prevalent.
And then exploitation, does that include like financial exploitation?
does.
Is that predominantly what that is, that kind of exploitation?
It can be, or it can be, people mostly financial, I will say, but it can be, you can exploit people emotionally by, manipulating them into making, them feel bad for somebody else. So it is, I would say mostly financial, but it could be in other forms as well.
All right, thank you. Question, Representative Tversky?
Thank you. Good morning. Thanks for being here. I don't know if we're going to get to this in the coming slides. If so, put me off. I have a question explicitly about HB2 that affects your department on page 49, section 98 at the bottom, regarding congregate housing and services, that it will be suspended for the coming biennium. Can you please talk about that and the impact of what that could have?
Yes, I will get to that.
Great.
Okay. Yes, I will talk
Looking
about that.
forward to it. Thanks.
Okay. Yes, thank you.
Are there any other HB2 items in there? I think that's a great question, but do we have multiples of them you want to go over?
That affects this bureau. I don't know, but that one jumped out to me
Okay,
in the
thank
last
you.
couple days.
All right, great question. Go ahead, Representative Wallner.
Thank you. So while we're at the Adult Protective Services, how many Adult Protective Services workers do you have?
In total, we have 70.
And what kind of a caseload are they carrying?
They're carrying about 97 individuals on their caseload, which is there's no national standard in caseloads for adult protection. We're really working with the national folks on developing something like that because there is no standard. I think in other avenues that provide protective services, they do. But there is no national standard. Certainly, we would like that number to come down. As our aging population grows in New Hampshire, we just expect the number of adult protective cases to grow. I do think we have some opportunities to better partner with some of our community organizations. If it's not necessarily an abuse or neglect area that somebody needs, more information or referral or community-based services to be able to hand off that from an APS worker to a community-based provider. So we're working on those connections as well.
Go ahead.
So do you have, on all of these cases, does the caseworker have face-to-face interaction with the client?
Yes, yes, I'm looking at my team back there.
I see the shaking head
Yeah,
out there.
yes, face to face, and so you can tell. I think they use a priority. That we have some decision making trees that we use in APS. It's to kind of see which person should be seen sooner, which person maybe be able to be helped by an aging or disability resource center, maybe somebody else is being served by the Bureau of Mental Health Services. So we have an algorithm to kind of prioritize those at higher risk.
And one other question, is there a hotline or a referral number that the public has?
Yes, I think it's on one of the slides, and we
Okay,
also
that's
have
fine.
now, as part of our IT solutions, we also have 24-hour reporting online, so anyone can report allegations of abuse or neglect. That's on an online portal that people can submit, and that's something new that we instituted this year. So 24/7 ability to report.
Great, thank you.
Representative Priest, did you have a question?
My question was the same as
Okay.
the previous representative. Thank you.
I think you can continue.
On slide 17, we talk about, this is where we have the APS accounting units. I didn't know if you had questions or wanted to review this. We do. You can see here in accounting unit 9250 was where all of our APS staff are housed and paid for. Significant general funds there. That's historical for APS as far as the federal government not funding the service. However, in 2023, they started giving us a small amount of money, which is that accounting unit 4046 for adult protective operations. So we're starting to see a little bit of assistance with the federal government in providing funds for adult protection.
Can you jump to slide 22?
Yeah.
Or did you have things in between you wanted to highlight? Go ahead, turn your mic on.
Before we leave this slide,
Yeah.
quick question.
You're still on 17?
Yes.
Okay.
Just helping me with the terminology of minimum allotment state. Could you explain what that means?
Yeah, sure. So the federal government has a formula in determining how much states will receive in federal dollars. So looking at, I think Maine, Vermont, and Rhode Island were all a minimum allotment state due to a couple of factors: population, people who are in poverty, number of aging adults. So they look at all of that and create a scale in which states receive those dollars. So a state like Massachusetts, I was looking at the numbers, they receive a bit more, but I would only say maybe like $20,000 or $30,000 more, not a significant amount of money. And this amount of money for the APS formula grant is pretty low comparative to other federal funding, but it's a start. We'll take it. Welcome.
Are you on 22 now? Or is there more question?
Okay, slide 22 is our aging and disability resource centers. So I clustered these together for a couple of reasons. Again, this is kind of how we see the braiding of funding work. So in 9565, that is where our funding for our ADRCs, or Aging and Disability Resource Centers, also known as ServiceLink, previously known as ServiceLink. We have 7 contracted providers at 13 different sites throughout the state. They provide information referral supports, person-centered counseling. They administer our family caregiver support program throughout the state. And also, they were given additional dollars in HB2 of 23 to enhance the system of care for healthy aging. So we have that. We also, in 3317, we have the Senior Medicare Patrol Program, mostly federal funds, that teaches older adults who are on Medicare to look at and be aware of any Medicare scams that might be going on. And then 8925 is the Medicaid Services Grant, which is a state health insurance education program. 95% federal funds, and it really is a counseling program to help people understand their options when it comes to Medicare. Any questions on those?
I don't see any.
Slide 23 is just a kind of a visual on the system of care for healthy aging. So just wanted to point out, we are underway. We were able to, again, secure that funding in HB2 and 23. So that included a study to look at our coordinated system, some funding for IT technology to create dashboarding, reporting requirements. We did get a good significant amount of funding for person-centered counseling programs that are within our ADRCs. And the department received 2 positions to help with the system of care for healthy aging. So that was in HB2. This graphic really just shows, obviously the individuals that we serve in the middle, and then all the supports and places of support that people can go to in order to navigate that system of healthy aging.
Go ahead, Representative Tuloski.
So slide 23 is all about this wonderful work that happened with HB2. Last biennium, where are we going to be at now in this biennium with this same work? Are we going to be able to continue it is my question.
Funding wise or just programmatically wise?
Both?
Okay, I could talk. From a program standpoint, our next steps in the system of care for healthy aging is we still haven't completed the dashboarding piece. So again, kind of the IT in real time, so people know what services are available to them. If a provider has a capacity to take on somebody who needs home health care, for example. So that has yet to be completed, but that's part of that appropriation in HB2 of last year. We have been able to start, and what we're seeing is an increase in home visiting with the inclusion of the dollars for the person-centered counseling. So we've been seeing the number of home visits from those individuals that work at our ADRCs to go out to the home. And kind of, it's always good to have an extra set of eyes on somebody, or if somebody physically can't come into the ADRC or have communication issues through telephone. So we're also ramping that up as well within the ADRCs. We have 63 staff statewide in our ADRCs. That's just in a brief kind of overview of slide 24 of what they do, which I talked a little bit about: person-centered counseling, access to family caregiver information, and explore options that, are either covered by Medicaid or Medicare. Slide 25 is just the locations that we have throughout the state. So walk-in locations, physical locations for people to come in. And again, those workers can go out and do home visiting for people that can't come in. Slide 26 is just a breakdown of the total encounters in state fiscal year 24 that our ADRCs had. And also, again, I'm focusing on the home visits because I think it's really important to have eyes on some folks. And then kind of total staffing by each ADRC.
So I have a vision of a virtual healthcare system to where we don't need to move people around on roads as much. How long do you think it might be to where we can provide a tremendous amount of this support virtually through something like telemedicine instead of spending windshield time moving people around.
Yeah, I think we do a lot of that now where a lot of our encounters, we call them encounters, but are either, on a Zoom or on Teams or via telephone. Not only for, I think we learned that through COVID that we can get a lot done without being face to face with somebody physically. And it allows us to touch more people, to be able to be more efficient in our time. So, time traveling from Claremont to Colebrook isn't really efficient. So if we can leverage those and connect more providers with that telemedicine piece.
So would you say you're about half of your visits now are virtual?
Oh, I would say more than half are, either via telephone or visual or virtual.
And do you see us hitting 80% at some point?
I would think that would be a good goal. I don't know. I don't have
Yeah.
the number now, but I would think that, the number of in-home visits would really be limited to people who may be at risk or people
Right.
that don't have the ability to navigate technology
Right.
or have the ability to, have the internet or, some of those other barriers.
So one last question here, and then I think Representative Wallner has a question. But Dr. Ballard chairs a telemedicine committee with people from around the state, and they try to aggregate data that reflects the changing use of that's just generally called telemedicine. Do you think your data ends up in his data sets?
I wouldn't at this time. I don't think so because it's not considered medicine. I'm not sure if he's coming from a medical provider.
Yeah.
Telemedicine view.
If you ever have a cup of coffee
Yeah.
with him, ask him about it.
I will.
Because what we're trying to document in that committee is the changing nature of healthcare delivery and what we may do to facilitate it to make it go faster. So, all right. Representative Wallner, did you have a question? Representative Tulerski?
Thanks. Can you explain to me why the Hillsborough County numbers are so low on these home visits and encounters when it's the largest county? I don't understand that.
I think part of it has been our ability to retain staff in that specific office. So just our staff capacity, which we're seeing improve. Other than that, I don't have another answer as to why that's lower.
That's concerning to me. Okay.
Do you have a follow-up?
My follow-up is I'm really concerned looking at that number compared to Rockingham County and Merrimack County, which it's half of those counties. That tells me that there are a lot of people who are not getting the support and the contact that they should be getting.
Yeah, and I think if you're looking at the particular home visit number with 37 in 24 and 25, for the half a year that we've been, or a little bit more, we're up to 24. So we are seeing a little bit of a climb. Their encounters, though, if you look, that's still 6,716 encounters. So that could be, again, it could be a telephone call, it could be a Zoom meeting. So not necessarily a home visit, but we still have a significant amount of encounters. I do see like Merrimack County and Rockingham County have higher encounters than Hillsborough County.
Yeah, I mean, just if you look at population alone, Hillsborough County numbers of contacts encounters should be up there with the other two, if not more. So, okay, thank you.
Representative Daniels?
And just following up on that, you list the number of home visits, but you don't list the number of homes. So, going back to Hillsborough County, 37 home visits, but how many homes did you visit?
It's a good question. I can look at, I don't have it with me, but we can get some unduplicated counts. So number of actual people versus if I go to a home 2 times, 3 times, is that counted as 3 visits or 1 visit? I can get that for you.
Thank you.
You're welcome.
And of course, however you're doing it, the data would be captured consistently. Well, like we wouldn't have a Hillsborough issue where they may be reporting the data differently, even though
Yeah, everyone uses the same reporting, so I don't think it's a data collection
All right.
issue. Slide 27. is our accounting units for, again, still in our same bureau, but our Administration on Aging, our Social Service Block Grant, and our volunteer opportunities. So 7872, the Administration on Aging funds a variety of different services. So anything from nutrition services, home modifications, and caregiver support. In 9255, that's our social service block grant. Again, funds things like medical adult day services, in-home care, chore services, emergency support, respite, home delivered meals, and homemaker services.
So is this, I assume Meals on Wheels is part of that?
Yes.
Are all of Meals on Wheels in this area, or are they spread out in multiple accounting units?
They are spread out in multiple accounting units. So certainly they are under the Administration on Aging funds. They're in the social service block grants. They're also in, we have a significant state funded portion of meals and nutrition.
Do you know if we do one big contract with them, or do we do like 12 different
Nope.
contracts per program?
Yeah, so for meals, we have 10 contracts that braid all that funding in together. So 10 providers with their contract, but includes, funding from the Administration on Aging, from the block grant, from the different sources.
All right, thanks. Representative Novenko?
Yeah, and, and looking at page 900, I'm just is this another case where we have a crosswalk issue where money, I see, there's 100,000 in there for fiscal year 25 adjusted and then goes to zero? Is that another, where it's shifted to another accounting unit?
You're looking at 9010, class 103.
Yeah, I'm looking at 103 and I guess I'm looking at,
Yes, so there was in Chapter 79 Laws of 2023 HB 2, there was an appropriation made for the foster grandparent program, which is currently not funded.
okay, so that's why it went to zero? Okay.
Yes.
And then the other, a quick follow-up on the volunteer activities. How many people are we serving there?
I do have that. I just have to get to the right page. So for the volunteer, it's the Senior Companion Program, which has been in existence in New Hampshire since 1974. And so when we look at 2024 numbers, we have 75 companions that have provided over 53,000 hours of services to 457 older adults. So that funding provides, mileage reimbursement, a small stipend, education and training to those senior companions.
Okay, thank you.
And Chairman Edwards,
Yeah.
if I could just add one thing. On the, in the accounting unit 9010, class 103, because the foster grandparent program is not funded in the current biennium, I did send Kevin an email over the weekend indicating that we'd probably want to consider suspending the corresponding statute for the biennium if that's not going to be funded going forward.
All right, good catch. You have that on our HB2 list? Yep. Go ahead.
Any questions on slide 27? Slide 28 is specific to nutrition services, so just giving you some information on the satisfaction surveys that we send out to folks that access nutrition. So it could be Meals on Wheels, it could be our grab and go services, or it could be congregate meal settings. So, we serve a lot of people, over 37,000 folks. We've served over almost 2 million meals. I think one of the things I want to highlight is that from a Meals on Wheels perspective, 61% of our folks say it's their primary source of nutrition. And then, 41% say it's the only person they see all week is the person that delivers their meals. So not only is it providing nutrition services, but it also provides another layer of support and oversight of folks. So if somebody didn't pick up their meals, our Meals on Wheels providers are great at notifying, either their agency or us to say, we haven't seen, Melissa in a couple of days. I think we need to check in on her. Or I saw her and she was looking a little different today. It's a great, supplemental set of eyes for people who are homebound and receiving meals. So not only does it provide nutrition, but also that extra layer.
So I love Meals on Wheels because I had surgery on my ankle like a year or two ago, and I was stuck in my comfy chair for 3 months. And they would come into my house and feed me right there at my chair, and ask me how my day was going, doing like a little mental health check.
Sure.
I don't know if they did that intentionally, but it was there. The only issue I had with them is that they didn't do weekends. They didn't do Saturday and Sunday. It was Monday through Friday. It was one meal. And for a big fat guy like me, it wasn't enough food. But other than that, they were really good. Representative Wallner?
Thank you. So when Meals on Wheels goes out and delivers a meal and a day goes by or 2 days goes by and they haven't seen anyone, who actually then follows up? And do you actually go out to the house?
Yeah, so with our contract, there is kind of a safety net. So if somebody does see something like that, they report it to their supervisor. But we have contract managers that manage all the 10 Meals on Wheels contracts. So the expectation would be that they report up to us. And then we can partner either with, the local ADRC, or if it's something that we're concerned from a protective standpoint, we can look at adult protection or even a wellness check through the local, police department to make sure that person is okay.
So can I do a time
Thank
check?
you.
Yep.
I think we've got 40 more minutes that we're pushing towards, and then I want to open up for some questions around possible shifts to MCOs.
Yep.
So how do you think we're doing? You got another 40 minutes? What do you think?
For, I would say we still have the developmental services waivers, which I think might take some time. So I don't know if you want to jump to BDS or if there are any large questions. We haven't also talked about CFI or nursing facilities in EAAS. You might want to jump to that first.
I think we might get to the CFI issue when we start talking about a potential shift to managed care,
Okay.
I think.
Okay.
All right. So as I'm flipping through the slides, I think, where do you think we can go?
I think we
You got
probably.
some good stuff in here, but but you have good write-up too. So can we just read those and we could get into the DD area?
Yep. I
I
was
have-
thinking we could do slide. Oh, go ahead. Sorry.
I had flagged a specific question
What-
that
do you
you're
have a
about to
slide
skip over. I'm
That
sorry.
you want to talk, you have a question you want to ask? I'm
A
sorry.
specific line item on HB1 that we're about to, you're flipping pages by that I have.
Okay,
sorry.
what page number would you want to have us highlight so you could ask your question?
On page 31, I have a question about the accounting unit 2152 that's found on page 902. I think this is the CFI and the nursing home.
Yes.
Is that correct? Okay. Looking at the 506 line, almost all the way at the bottom, it looks like there is a drop in funding to the 26, the 125. And I'm just curious if that funding that we put in there with the Medicaid rates last go round, if it's still in there, if they're going to be supported at the same level, or if there's going to be a change in the support that they get.
Your question is very clear. I'm just not tracking which pages
Oh,
and numbers.
page 902 of the governor's budget,
Yeah,
all the way at the bottom. There's actually a nursing home payment line, and there's also a home support waiver services line. And it looks like 504 nursing homes gets a big bump, but it looks like the home support waiver service does not. There's also asterisks on there with footnotes. So I'm just hoping we can dig into both of those and make sure that both of those are seeing the proper level of support.
Sure. So if you look at, so on page 902, account unit 2152, I'll start with line 506. So this is the CFI waiver payments. In the current biennium, this was the 506 line was budgeted at 92 million and 100 million. So what you're looking at there is you're looking at the actuals, and that has the applied rate increases from HB2. So when you're looking at the adjusted authorized, you're actually seeing a bit of carry forward that was not spent in the first year. So the projections going forward are based on the actual expenses, and the adjusted authorized doesn't necessarily, it's not necessarily a good comparator. But in the budget, we have incorporated those rate increases into that. Historically, we also used classes 505 and 529, but those have been wrapped up into class 506, which is why you're not seeing that anymore. And the reason that we did that was because we had some challenges relative to the administration of that. So if we needed to move money in between that, we could be looking at a 5-week delay, and we wanted to ensure that services were paid on time and in a timely manner. In the event we had to go back through. So that was a change that was made by this committee in consolidating those lines in the last budget. And in the next cycle, you won't see those lines anymore.
Okay. Can we talk about the increase in the nursing home rates, which does look like a significant increase?
Sure. So in the class 504 line there, these are the nursing facility payments for Medicaid eligible individuals. There's a bit of a history here. So in state fiscal year 24, the budgeted amount was 233 million. And you'll see that the expense there is 263 million, so about $30 million higher. I believe Henry Littman and or myself have talked to the fiscal committee and members of this committee about some of the nursing facility change of ownership challenges that the state has been seeing, where we've seen, I think, 18 nursing facilities change ownership. That's led to a number of downstream issues, including back billing, which has been pretty significant. Last year, I don't remember off the top of my head, but I thought we saw over $14 million of back billing from prior years. And that is a historical anomaly and likely a function of both delays in billing during the pandemic, as well as the change of ownership issue that the state is experiencing. When you look at state fiscal year 25 and the adjusted authorized, we have already moved through the department-wide transfer this year so far. I believe it was $10 million already. In this year, we're expecting to have to move an additional $10 to $30 million as well to continue to deal with the back billing issue. So when you look at state fiscal years 26 and 27, we looked at a period of 8 years of growth to estimate the numbers that we would need based on trends in utilization. And that's why those numbers are showing an increase there.
Wow. Okay. So it's not necessarily choices being made to sink more money in the nursing homes as opposed to CFI, which keeps people in their homes. It's
Yes, it's correct.
Administrative delays and snafus and payments that we're just trying to pick up the pieces and backfill, as you said.
I think it's more than administrative delays. It's some of the challenges that we've seen with ownership that are resulting in those things. So that may be the effect, but when you're looking at the cause, it's where, I think Henry said the other day, we've had a third of our nursing facilities change in ownership in the past couple of years.
Okay.
That's pretty significant, and that has caused a degree of instability, and it's affected the back billing that we've seen. Included in there as well is also the rate increases from HB2. So there's a number of different factors.
Okay. I just wanted to make sure that this was not a investing in nursing homes as opposed to CFI, which we all know is not the best choice.
That is correct.
Thanks.
So my impression over the last year or two is the department really prioritizes the CFI and trying to make it happen. So, if it's not reflected here, it's not a reflection, I think, on their prioritization. They were having other issues with getting CFI really rolled out. Yeah. So Representative Stringham?
Yeah, I mean, my understanding was, yes, CFI is prioritized over nursing homes, but nursing homes are prioritized over hospital stays. And that part of the reason why we were supporting rate increases in HB2 last biennium, and I guess, the suspension, pro share increase or something, the 2%, was so that there would be more nursing home capacity to free up the hospital. One of my questions is, what percent of the beds and our county increased, opened a wing and increased by about 15% in the last 2 years, the number of individuals they're able to serve. So I'm wondering what percentage of this increase is due to more people taking the service versus the rates, if we have that. And then if you have numbers of what percent of the beds are private versus county, that would be interesting.
I do know I do know there's reporting on the fiscal committee dashboard that looks at trends as far as utilization in nursing homes, like a 3-month trend, so we can see the number of people that are served in nursing homes. I don't have that in front of me, but we can get that to you as far as looking at those numbers. I will say that nursing facilities do play a vital role in our whole system of care, whether it's, providing short-term services for people to get better and transition back to the community, or for people who truly require that level of care and supervision. So it's not to say that they're not prioritized, because people generally want to live at home, right? Nobody kind of says, I can't wait to get into the nursing home, but the nursing home certainly is a part of our system that's vital, from a step down from a hospital, and then hopeful transition onto a CFI or other supports that we have to maintain, more preventative services from that hospitalization back into the nursing facility.
So, a little editorial note in here. I believe the department is tracking over 100 questions from us. Most of them are informational. Some of them drive directly at decision making. We'll need to make with a focus, I think, on general funds management. And so I've asked Mr. White, as he's going through the 100 questions, to prioritize those in which, in his professional discretion, think are probably related to us making a dollar or manpower decision relative to good information, good background about the situation. And not that he's going to lose those or forget those, but just if you've been asking questions and wondering where the answers are, I think we got to prioritize the answers that may drive budget decisions. So. All right. Do you have other questions?
I think it's a good point, Mr. Chairman. I would say in this area, we're going from 120 million to 180 million
Yeah.
over the biennium in general funds for
Right.
nursing homes. So
Go ahead.
Are there any other questions on slide? I don't know, I think we're on slide 31. Okay. Slide 32 is just some information about our CFI waiver. Again, informational for you. So just our eligibility work, some of our eligibility requirements, some of our services that were delivered, and the average cost based on claims in the past. So you can see, obviously it's less expensive to take care of somebody in their home than it is in a nursing facility or in a hospital setting for long-term placement. So it is a priority for us and federally to maintain people at home. It's not only where people want to be, but it's also a lesser cost service. Slide 30.
So,
Oh.
I'm a little slow.
You're fine.
So on 32, under the service examples, I'm just wondering if in the future we should be explicitly pointing out that we're providing virtual support or virtual services, or I don't know how you'd want to phrase that, but I do like the idea of making it more clear that not all of these are people standing in somebody's house.
Okay. Thank you. Slide 33 is just more of a procedural slide on how the department works with our contractors to determine eligibility for CFI. So it's a process where we contract with a contractor that goes and meets with the individual in person, does an assessment, brings that information back to the department where we make the decision if somebody is eligible or ineligible from a medical standpoint for CFI services, and then go from there. So if somebody is ineligible for CFI, what other services can they be connected to, whether that's services through the block grant or Older Americans Act, to prevent, nursing facility placement or hospitalization. Slide 34 is just trending over the past since 2004, looking at our trending from the orange line is nursing facility totals and the blue line is CFI totals. So we're seeing, a little bit of growth there as far as, moving from institutional-based care to home and community-based care.
Representative Wallner?
So this indicates the number of people, not,
Yeah, this
Not defined.
indicates the number, the
clients.
percentage of clients that are in CFI versus nursing facility.
thank you.
Slide 35 is more accounting units. So Money Follows the Person is 100% federally funded, helps people transition and stay in the community. We have health promotion contracts. We have the Alzheimer's disease and related disorders, which is 100% general funds, but 100% of that funding goes to individuals who are caring for somebody with Alzheimer's disease in the form of a respite grant. So it could be, providing home care services, or a respite stay for somebody in a facility for a caregiver that needs a little bit of a break. So 100% of that money goes into grants for caregivers. And then 2165 is civil monetary penalties. Those are the penalties that are collected based on citations from nursing facilities and then reinvested into programs and services to make the quality programming in nursing facilities better. So it's fines that are collected and then reinvested into programs to help people in nursing facilities.
Representative Tulowitzki?
Quick question. My previous question about HB2 and Chairman Edwards says, is there any other question on HB2? And I did do a quick search. This isn't necessarily what this division looks at, but there's a change on the Commission on Aging, which I assume you are somewhat connected to. What is your take on the changes in there? It looks like it's adjusting the membership in some way.
Wendy Altman is my bureau chief who serves on the Commission of Aging. I don't know if you want to take a mic and...
You can sit at the end of the table and use that last mic, and we just need to make sure the clerk has your name.
Good morning. Just for the record, Wendy Altman. I'm the Bureau Chief of the Bureau of Adult and Aging Services. I am the designee from the department who sits on the Commission on Aging, the Governor's Commission on Aging, and certainly support the amendment that they were putting forward to add an individual to the commission.
Thank you. It specifies a change in the length of the terms.
Yeah, we talked as a commission about those changes, both to adding an individual and changing the terms, and we didn't have any opposition to that.
Thanks.
Representative Nalvanko?
Yeah, I had a quick question on page 35. I'm just kind of curious as to why the Alzheimer's disease and related disorders is 100% general funds, given the fact that Alzheimer's and the aging population across the whole U.S. is, been pretty prominent over the last several years. Is this an allocation issue, or money for Alzheimer's is showing up someplace else from the federal funds, or just a peculiarity of what's funded and what's not funded?
Sure. I think part of that is, we do get family caregiver support dollars through other funding streams federally. This is a portion where the state pays and really provides that respite care grant. I think it's $2,000, per person, specifically for those caring for Alzheimer's. So it's not like they're excluded from the family caregiver support program. It's just, we're seeing obviously a rise in older adults and the need for supporting them in the community. So we think it's a pretty vital service. We just recently did a campaign on brain health and awareness, which I think is on one of the slides, as far as I think that was an allocation in HB2 as well, to make sure that adults are getting screened, and the importance of, recognizing early signs of Alzheimer's and dementia. So it's not that it's not covered, again, kind of piecemeal with other funding sources, but nothing, as specific as this, where 100% of these dollars go to families with caring for somebody with Alzheimer's.
So it's just an allocate. The fact that it's 100% general funds is just a decision internally to how we're treating allocations from federal money.
I think it's a supplement to the allocations that we're getting from federal dollars. I don't know the history of this line item as far as how it, originally got into our budget, but historically, it's been in there for, 100% use for families.
Okay, thank you.
So I don't know if now you want to jump to developmental services. We can start on page 41.
And you'll also be moving forward in the governor's operating budget to page 1014.
So we have accounting unit 7100 in the Bureau of Developmental Services for developmental services. This is the developmental services waiver. It's 50% state funds and then 50% federal funds for those who qualify for developmental services on the DD waiver. So it serves about 5,061 individuals on the waiver, administered in partnership with our area agency system and our community-based service providers. Accounting unit 7016 are acquired brain disorder services. It is, again, a waiver service to waive institutional care for those who qualified under a acquired brain disorder. The waiver itself is 50% federal funds, 50% state funds. It also has an allocation for support of the New Hampshire Brain Injury Association, who is our content expert on providing services and linking information and referrals to those who are newly brain injured or those who have a longstanding sustained brain injury, and provide really great support to those folks. So that is also included in 7016. 7110 is our children's in-home support waiver. So this is completely self-directed by families for children who are in school. It is, again, 50-50 funding source for federal and general funds, and it's for kids with developmental disabilities to stay at home with their parents or family and receive services in the home. 7013 is family support services. This is 100% general funds. This funds are 10 family support councils, which are located within the 10 area agencies, and also provides operational funding for our 10 contracted area agencies to support individuals and families, particularly those who are not on the waiver or not eligible for Medicaid services or services funded otherwise.
Representative Stram?
Might be jumping a little bit, but we're spending about 75,000 a year on the DD waiver program and the acquired brain disorder, about 95,000. First question I have is, given the number of people we have in there, what's the range of the amount we're spending per individual? Do you find it's very, very narrow, that almost everybody is very close to the mean, or is it vastly spread out? And, or, are there a few people that are using a substantial part of the budget? That's the first question I had.
Yeah, I think with the work that we're doing in IT, it's helping us determine that. Before, it was kind of, we weren't able to track, let's say, trends in, utilization of a specific service. But I will say that we see people on the waiver who are lower cost, using those lower cost services because they are more independent. So they might just need somebody to help them with transportation or help them in their jobs, so supported employment. But we also have folks that, require some really intensive needs. They require residential services with somebody with them all the time because of their, behavior, because of their, developmental disability, and really need, somebody one-on-one. So we see a range just based on, our person-centered plans for our individuals.
So you may see a significant number of individuals in the program using, say, less than $10,000 of services in a year, do you think? Or is that number even?
Could you make sure you're hitting the microphone?
I have, but I will speak into it. Yeah.
Thank you.
Thank you.
I am trying to find my average. I do have an average cost of, somebody on the DD waiver. Give me one second.
Your slide 42 has 73,739 as an average.
Right.
So, I was
Yeah,
just
so
kind
that
of
takes
talking
in-
about the spread.
Yeah, so that
What-
takes into consideration those who, utilize the lower cost services or less number of services, and those who have, high intensive needs services.
So what do you think the most expensive person is in there? Is it 5 million, or is it?
No, I wouldn't say 5 million. I think we've seen some budgets, for folks who require maybe 2 staff members with them at all times. Probably could be as high as 500,000 per year. And that's why we really advocated for rates, so we can predict, that cost. Right now, it's really what the provider tells us they need in order to provide services to those folks without, the guardrails that a rate system would put into place.
So, last term, we put a lot of emphasis on these rates, but just at the waiver program as its entirety, not going into the individual services, it sounds like you're doing a tremendous job trying to automate and be able to collect and analyze information. Secondarily, I would hope understand which of those services are particularly valuable to those in the waiver programs. Do you have, as of this point, say a list of what the top 10 services are in terms of what in the DD waiver program that we're spending money on at this point?
Yes, I don't have that with me, but we are tracking that information. I will say to the first part of your comment, when we were looking at rates on the DD side, we did significant stakeholder engagement, not only with area agencies, but with providers, with people who receive the service, and listen to them as far as, what do you need in order to be successful in the community where you want to live. And so that's how we prioritized specific services that we targeted rates to, based on that feedback, and also based on a cost analysis of providing those services versus a higher cost residential service.
So you're saying with the last waiver increases, you didn't spread them equal percentage across everything. You targeted them based on getting the best need for the those individuals in the program? Is that
I would say for the last waiver increase, it was probably, I think it was for case management. So we haven't received an appropriation for this rate development. That's why we put that forth as a prioritized need in order to do this plan of prioritizing services that the people and providers have told us that are important for them. As far as any rate increases, I believe it was across the board. It wasn't focused on a specific service.
so? I still hear concerns, and I call it the 25-cent hamburger. Everybody gets a hamburger. Here's your coupon for 25 cents. Turn it into anybody you want, and they'll give you a hamburger, and they send it to the state, and the state will pay them 25 cents. It's pretty hard to get anybody to take that, and some of the services in the program, particularly in the last, before the last biennium, were extremely difficult to fill at the rates that were there.
Agreed.
But we probably wouldn't hear about those that are easy to fill. So without digging into what those services are and how they serve those individuals, it's hard to make specific recommendations in HB2. But if you have the list of top 10 services and how much dollars that represents, I would be interested in that. Thank
Sure.
you.
I think in a later slide, probably at the end where the prioritized needs were listed, we listed, the services that we wanted to include in the first phase of, if rates were funded and the fiscal impact of those rates based on not only utilization, but low rates. So if people want a service like community participation services, but our rate is so low, we don't have any significant number of providers to provide that home and community-based service. That's where we come into this, quandary of I can give you your 25 cent coupon, but if I don't have a provider gonna give you a hamburger for 25 cents, then you're stuck with your 25-cent coupon, right? With no service or no hamburger, so to speak. So I think that's, why we feel that rates, not only in DD, but in CFI are important in order, to attract providers to come. As a provider, you don't want to come into a state not knowing what you're going to be paid to provide a specific service when it's something that's not controlled and measurable measured as far as what does it cost to provide that service, not, I'm telling you it costs $500,000 to provide me services. So we need that sort of methodology and framework in order for us to look at our cost containment, but also to make sure people are getting the actual services that have been funded or allocated to them.
So I have a question for you, Representative Stringham. I'm following your conversation, and it seems to me like somebody needs to say, "Where's the beef?" Somewhere in here. But having said that, where is the beef? It sounds like you have intuitively put your finger on a key service that you think is not being made available because of a rate issue. Do you have any specifics in mind that you might want to mention?
I don't actually. So,
Okay. You're just doing a sanity check on it.
75,000 is a lot of money per year, and we want to get full benefit for those individuals and put the funds to best use. So,
All right.
and I think we did some good things last term by prioritizing rate increases or
Right.
rate adjustments to areas
Right.
that helped.
Okay. Well, thanks. I just wanted to interpret what I was hearing from you a little better. Thank you. Representative Priest?
Thank you, Mr. Chairman. Back on page 41, thank you for providing us with the number of individuals that you are servicing in the first 3 accounting units. Do you have the number of people that you have served, like in the past 5 years, to give us the information whether or not this number is increasing or decreasing, or I just would like to have something to compare this with the staff that was in place for those years.
Yes, we report caseload numbers out on the fiscal committee dashboard, so we can send that to you as far as, I don't know how far back it looks.
5 years
but
would be
yeah, at least
fine.
5 years is on there, so you can look at the number of caseloads and the trending of that.
That would be great.
So that's actually already online then?
Yes,
Because
it
all
is.
the fiscal committee statistical summaries are already there. But if you could send him a link just to get him going.
That would be great. Thank you.
Welcome.
Representative Seaworth?
Thank you, Mr. Chairman. My question is on the family support services. It's actually a two-part question. The first part, pardon me, I'm going to kind of repeat my colleague's question before. So this is a 100% general funds. Is this in service to a federal obligation, or is this something on our own initiative we decided it's necessary?
Yeah, it's in statute in New Hampshire. It's not a federal statute. It is under 126G for family support to provide assistance to to families that are taking care of individuals with developmental disabilities. So it's within our state statute, and then providing operating costs for area agencies to take care of those individuals that don't have Medicaid coverage or any other insurance coverage. The area agencies are obligated, if somebody is determined eligible through 171A, to provide developmental services, and not necessarily based on if you're eligible for the waiver. So we have a lot of supports that the area agencies provide to people who don't qualify for Medicaid. And so providing funding to the area agencies to keep families, in order to keep families as, the primary caregiver, but supplement the cost of doing that. But not a federal statute.
RSA 126G.
Yes, and my second question, I almost thought it was anticipated it was going to be answered, but so what it looks like to me is that it's the second bullet that you mentioned and the other RSA reference, 171A. I can certainly go home and look at that, but if there's a quick elevator summary, because it looks to me in the budget that that's some new funding in the upcoming biennium.
So if you, I believe you're on page 1018 under
Correct.
7013. So there's two class lines there. The first class line, that has the Family Support Council dollars budgeted in state fiscal years 26 and 27. And then in class 103, that is the contracts with the area agencies that are budgeted there. These were both previously budgeted in class 102, but we tried to separate that out to make it more transparent going forward and just easier to track.
And so the difference between 24 and 25 in the 102 line is
The difference, so if you were to turn to, give me 1 second here. So if you were to turn to chapter 106 in the current operating budget, it's budgeted at 4.467 million each year. What you see in the state fiscal year 24 actual expense is you're seeing delays in invoicing and billing. So the expenses did not occur at that point in time, but the budgeted amounts have remained flat biennium to biennium.
Thank you for the explanation.
So you got me thinking about line 103, the $2.9 million, that those are contracts to area agencies to provide area agency kind of activities, I suppose. And I think we talked about it in January, but I asked the question, we've got 10 now. If we were to reduce that to 8, would we save any money? The testimony of the department at that point was no. You would just, move parts and people around, but it would be the same cost. Is that still your position?
Yes, we serve a very niche population, so that population doesn't change. The number of people we serve wouldn't change. It would just, go to a different agency. So we don't believe it would be a significant cost savings.
And then the big procedural shift I think we've seen in the area agencies is previous budgets, area agencies were responsible for doing basically the billing for the providers, and we've gone to an independent direct provider type of billing.
Correct.
Was there any cost savings to our contracts to the area agencies since we're asking them to do less?
I think they're two separate functions. So I would say that we've actually seen, we're tracking month over month the actual spend on the waiver to see, now that the providers are able to directly bill instead of having to bill through the area agency. Are we seeing an increase in billing or a decrease? We've seen a pretty, I think I have a slide in here. We've seen a pretty consistent amount of billing, whether it's from an area agency for services or from a provider for services. So we haven't seen, a cost shift in that.
Okay, and then it was part of the A&M recommendations where there were three major things that the department wanted to do in the current budget cycle. One of them was the transition, the billing, and then there were two other, and I forget what the two others were, but you all ended up postponing it to adjust the absorption rate by the area agencies. What were the other two items that were on your list of A&M recommendations?
A few. So we had recommendations for IT enhancements, which is certainly something that we have been working on. That is not, it was briefly paused as we were trying to figure out operationally how that happens with the area agencies and making sure that they have sufficient software technology in order to change that practice. So we had IT enhancements. We had investments in intensive treatment services, which we have done through federal dollars with our ARPA grants that we've been able to open or at least fund at least 115 new beds in the community for those who need a higher level of care instead of having to move out of state or receive services away from their families. So that was the other suggestion that they had.
Okay, and so just to wrap all of that up, I think we paid A&M, I don't know, $15 million for their consulting, and they gave us at least these three big recommendations. Can we project any savings or additional revenues that come from that contract we invested in? Are we going to get a return on investment for that consulting?
I think that's a broader question that I can bring back because I'm going to have to pull in a couple of different folks from different areas. There was a lot more work. I mean, currently they've been providing us assistance with the community reentry that we previously talked about when Medicaid was here. When Dave Wieters was talking about the modularization of the MMIS system and moving that towards more of a modular-based approach. So there's quite a few other elements that they've been helping us with. In the current biennium, there has been a significant reduction to that Alvarez and Marcel contract. So going forward, it would only be the DD work and the MMIS and the other work streams are being retired out from that.
Right. And do you happen to recall offhand what the hourly bill rate is for A&M? I've heard 180. I've heard 240 an hour.
The billing is based on a monthly amount, and so we receive a certain chunk of resources and work hours, and then the billing is done on a monthly basis. I don't recall off the top of my head. I'd have to go back and get that.
Okay, so I'll just say one thing that's been whispered to me in hallways is it would be much smarter if we went and hired one or two really smart people that can step in and take over the A&M implementation roles so that we're spending money within our employment structure rather than contracting that out. So I'm not gonna ask you your opinion on that here, but I just want to share the feedback that I've been getting about the A&M contract. So if there's something to that idea that you want to act on, come back and let us know. Okay. Do you want to continue?
Yeah, I think one other point I just want to make within slide 41 is that our rates were based on, we used another contractor, not A&M, to look at, the cost structure of those rates. One of the components was using an assessment to assess the level of need that an individual may need as far as a support, the supports intensity scale. And that is not only in our rules, but in our waiver that has been unfunded. So that would be, I'm just trying to put a plug out there as far as considerations for, our rate-based methodology is, a component of that is having that individual assessment of need for people on the waiver who are adults. So I just wanted to put that out there.
Was there a question over on this side? We saw movement. Nope.
Slide 42 is, again, just examples of our 3 waivers in developmental services and the average cost, historical average cost per year, services rendered, and eligibility requirements. Slide 43 is a billing slide, which is 25 data. And I just wanted to point out, you can see that in that first box in the upper left-hand side, 92% of the billing is for the DD waiver. So you can see we have, that's where most of our billing goes, is for those services. The major service types of billing that we're seeing is 67% for residential services and 23% for day services. So we have a monthly billing average of about $43.4 million for the DD, for all of the waivers in BDS. So we're seeing that pretty consistently since we've been tracking we've been tracking longer, but since July 24, you can see that's pretty consistent billing.
So because I'm trying to manage the time,
Yep.
would we be missing something significant if we went to slide 50? That's where the prioritized needs are.
Nope, we can do that.
I don't want to jump something that you had put an asterisk by to make sure we heard.
Just gotta find it. So starting on slide 50 is a list of the prioritized needs that our division put forth. You can see that for the BDS waivers, we were funded for our waitlist requests. So these are tracked for individuals who are projected to need services that are currently not funded because they're not in the system. So our area agencies help us in a registry system to project new people coming on the waiver and people who might need enhancements to the services that they're providing. So that was funded. That's what you hear when you hear the wait list. That's what was funded as part of our prioritized need.
So for the newer people to the division, and just to make sure I understand it, we often speak in terms of saying we are funding the wait list. And what that means is that the money is in the budget to theoretically pay for everyone that needs the BDS service. However, the reality is that there is often a disconnect between our ability to fund the service and the individual actually receiving the service. And so the real wait list is the number of people who aren't being serviced even though there's money. And so don't get complacent when you hear that we fully funded to make sure that we have no wait list, because that's not the question. The question is how many people need the service that aren't able to access the service. I think that's the effective wait list. And that's a harder statistic to maintain, right? But I think you all have broken the code, and now you report as routinely what the actual number of people who want services but can't.
Correct.
Okay.
Yep, and the reasons why. So is it because they can't find a provider to secure the service? Is it, they need Medicaid, eligibility? So there's a lot of factors that we now report out at oversight as to, yes, funding is, people are funded, but why are they not accessing the service? And that's reported to us from our area agency system. So that's, something part of our IT technology that we were able to build, but also really taking that stock and being transparent of, yeah, we don't have a funding wait list, but people aren't getting all the services that are authorized.
So this 44 million and 27 feels just like an enormous jump.
So you have to remember in 27, not only would you be funding the new people on 27, but you also have to annualize the folks that you're funding in 26. So you'll see, because if you fund people in 26, they also need funding in 27.
What's this isn't the right word, but I'm going to say attrition rate. We're looking for new people who need the services, while at the same time, at the back end of the system, people are no longer requiring services for a variety of reasons. So are you also projecting in this the attrition rate?
Yes, but I would say it's fairly low because these are services throughout somebody's lifespan, right? So it's not, if you compare it to somebody on CFI who's an older adult, I would say the attrition is higher because you have a shorter lifespan.
Lower range.
Right. And so
Whereas
we have,
these people's range is much longer.
exactly.
And so
So
forth.
you
There's
have
less
kids,
turnover.
you have kids coming in from school all the way
Okay.
through adulthood on, being eligible for DD services.
You made that make sense for me. Thank you.
Welcome.
What else?
So we also, we put in our prioritized need for CFI rate increase based on HB2 system of care, as we were legislated to do a rate study. So we put that in our prioritized need. We also, in listening to our stakeholders, put in a prioritized need for guardianship slots for people who are on the DD waiver and people, and older adults. Congregate housing, which was something that was unfunded, we put in as a prioritized need that was not funded. And then we have the BDS rates, which we've talked about. One really important consideration on page 51 is the prioritized need for room and board. We have providers on the DD and ABD waiver that provide residential services for people, and room and board costs are not covered by the waiver or by Medicaid. And so we have providers with rising costs of utilities, of,
So of this 10 million, how much of that is general funds? All 10 million?
all 10 million. And, I think there's a slide on kind of, I don't want to say a justification, but, the importance of, we've done work over the past 2 years in developing a formula for room and board rates as to looking at, what county you live in, the number of beds that you're certified as a provider in your home, looking at rental costs per county, looking at utility costs, phone and internet, property costs, which could include, snow removal, air conditioning, that sort of thing, and food costs. The real danger in not funding this prioritized need is that we've heard from providers that they just cannot keep the service going without those additional costs supplemented. And so, again, none of our Medicaid waiver dollars can pay for room and board. They pay for services for the individual. The individuals do pay toward that room and board cost, but it's not enough to cover the cost to keep doors open for our providers. So, potential concerns would be not only providers leaving the state, not attracting new providers to the state, but also unhousing people with developmental disabilities, and where would they go if they did not have that residential care?
Representative Wallner.
How many people would this affect?
How many people?
That's kind of a hard one to guess, I would think, because you don't know who's going to drop out and who's going to be affected. But
Yeah, yeah. I can look at more of the numbers on that. I can get you kind of the number of certified beds and who currently has room and board funding. But I would say even the current room and board funding that these providers are receiving is not enough without an adjustment factor to the changing costs and service.
I would appreciate seeing what, some sort of
We can do that.
estimate of,
so how many people
this
are
would
getting room
affect.
and board now?
That's a good question.
And then do you have a unmet need of the number of people who still need room and board that don't have it now? What are those two numbers?
Yeah, we certainly still have providers that are providing services without room and board. And those, as we were, creating a formula to make it fair and it used to be kind of first come, first serve. So if I was a provider and I asked for room and board, we have a finite amount of dollars currently that we can use for room and board.
Sure, I'm just asking client numbers. How many clients currently benefit from room and board, and what is our unmet
We got
need
somebody
for-
pulling up some numbers for us.
Okay. Because I think that gives Representative Wallner and the rest of us an idea of what the potential impact is here.
Thank you. She's looking it up. So
Yep.
as soon as we get that, we can.
Okay, she
Yep.
can continue to look it
Yep.
up. Let me do a survey question, and as we're pausing, are there members of the audience that would like to speak to the committee this morning before we break? I'm not seeing hands. I'm not seeing hands. Okay. Do you want to talk about recreation and early intervention while she's coming up with the numbers?
Yeah, we can talk briefly about recreation. As we know, that was funded in 2020, say fiscal year 2025 with $500,000 of general funds.
Yeah, how'd that go? Do we have any data on utilization?
We do. So I looked last night as I was preparing for this morning. So as of last night, we've authorized $367,539, which equates to 673 approvals and only one denial because that person was not receiving waivered services. So not part of the criteria to receive these recreation funds.
So were your big numbers 360,000 divided by about 227 users?
I would say divided by 673 users. So, and there's a cap of $600, so they
Yeah.
can't ask for more than $600 for recreation services.
Okay. Do we have the numbers on room and board clients? That's our, if you can't do it, then we can. We're about to hear, I think.
Good morning. I'm Jessica Gorton, the Bureau Chief with the Bureau of Developmental Services. And my colleague Lori Vachon is pulling the numbers of individuals who are currently receiving room
Yeah.
and board funding. We have about a list of 500 individuals right now who need room and board funding that's been provided by our provider agencies.
500 in addition to whatever number we already are supporting.
In addition to the current spend, which
Yeah.
we typically track by provider, but there should be very quickly able to divide that by the total number of individuals.
Right. So the immediate threat is probably could be summarized that those 500 may not be serviced, and that of the existing client population, they may be harmed because some unknown percentage will have their room and board removed.
Absolutely, due to the total impact to a provider agency as a whole and not any one particular home that they might be receiving those
Yeah,
funds.
Ms. Vachon, do you want to come up? Did you have a number?
Hi, thank you. I'm Lori Vash. I'm the Chief Operating Officer for the Division of Long-Term Supports and Services. At this time, we have a total of about 240 beds that providers could bill for. There are sometimes a vacancy if an individual passes away and then somebody else moves into the home. But overall, we have on average about 550 approved staffed residential individuals in New Hampshire. So that's the unmet need.
I'm getting my numbers confused. The current people receiving services sounds to be a little under 250.
No, so currently receiving, so we only have a smaller population that we're able to fund room and board services for.
Well, that's the
And
number I'm
that's
looking
around
for.
240 individuals
Yeah.
or beds in New Hampshire.
So we're only doing a third of the demand.
Correct, correct.
Okay.
And just to reemphasize what Melissa Hardy said, it's critical to keep those individuals receiving current services.
Yep. No, I
you.
understand. I think we just wanted to understand the context,
Sure.
the human impact in quantitative numbers. So thank you.
Thank you.
Okay. Do you have a question? I'm sorry. Were there questions over here?
There were questions over there, but I do have a question.
Representative Priest.
Thank you, Mr. Chairman. Back on page, just quickly, on page 50, on Guardian and on congregate housing, do you also have numbers of people that we serve and what's the need for that?
I do.
And you can provide this afterwards if it's not easy to get to.
Yes, I do have numbers for that I can get to you as far as the number of current slots that we have for guardianship. And then I know there's also legislation currently going on as far as funding this guardianship need, and what that would mean is, increasing the number of slots, but also increasing the rate that public guardians receive to provide that service.
Great, and the same with congregate housing?
Yes, congregate housing was something that was funded in HB2 and was not funded during the governor's budget. We have two providers that are housing authorities in Laconia and in Manchester that receive this support through congregate housing. So that could be support services, housekeeping services for those individuals that live in those housing developments.
Okay, thank you.
Go ahead.
So that was the question I had about the suspension in HB2. I guess my follow-up to that is all these other line items that are not funded on your prioritized list. Is that congregate housing the only thing that's in statute? How come that's the only thing that is suspended officially? That's a question for you, Mr. White.
Sure. So congregate housing, it was funded at 1.5 million via an HB2 appropriation in the current biennium.
Yep.
Prior to that, I would have to go back and look at the history. I don't know if Kevin knows off the top of his head. It's been unfunded for a number of biennia. It was one of the items last go around when Chairman Edwards asked the question of why do we keep suspending this? We've never funded it, but then last year we funded it. So different conversation now, but it just has a history of not being funded for some time.
Okay, so my follow-up question though is these other line items that were not funded, how come we don't have to suspend anything for those because they're not in statute or?
So the congregate housing, that's the entire program.
Yep.
So under statute, it directs us to have a program for that. But if we do not, then we would recommend suspending that. The CFI service rate increase, the guardianship rate increase, the BDS service rate increase.
Those are-
You're not closing down a program for a biennia, so you wouldn't necessarily need to suspend the state law.
So that was my question. So none of these other ones are full programs. Great. Thank you.
No.
Okay, do you have just a short summary? Because then I'm going to ask you about some questions that may affect some thinking around long-term managed care.
One other item just to be aware of that we previously discussed, just when we're talking about prioritized needs, in the governor's budget in the HB2, there is a provision to continue the DD pilot program that was originally authorized in chapter 79 for the current biennium. And that extends the program to allow us to continue to use the funds that were previously appropriated until the 7 or 8 individuals age off that pilot program. So I just wanted to highlight that as well, just as we're talking about DD.
Okay, so make it simple for me. Would that need to be another line on this prioritized need list, like an extension of page 51?
It would not. No action is currently necessary. It's section 104 of HB2 that
Yeah.
makes that extension. I just wanted to highlight that in case there were any consideration for changing that.
Okay,
Not that I'm recommending it.
all right. All right, so we have a few minutes, and so there's been some discussion, and this will be made more formal, Representative Tulerski, Representative Wallner. But I just want to start getting some thought out onto the table and in the public. There's been some discussion around maybe asking for this next budget to begin a transition period for the long-term supports, the CFI and the like, moving it into the managed care organization structure. And if we did that, the managed care organizations would then need to take care of issues like discharge planning, transitional care, other educational programs to physicians and hospitals. We would have to have the managed care organizations start to provide those services, and they would need to assist in collecting financial information, provide payment incentives to nursing facilities to reward reductions in several types of problems, and to develop a shared savings program for the county governments. So those are the big things the MCOs would need to do, among some other obvious implementation stuff. But then the counties would need to be more included more than they are now in doing the medical evaluations to help assess the level of need. And so there would need to be a transition period where the counties were able to establish manpower and training and put themselves in a position. I know that this topic has come up ever since we started doing MCOs, and I know that every time it's come up, a decision has been made to leave it outside of the managed care structure. But based on the rambling I just did, and you not having any paper in front of you, do you have any basic comments on this? I see Mr. Lippman has come in, and do you want to respond to that in any way?
I would want to recommend that, this was a discussion, I think, about 12 years ago. Having LTSS and managed care, I think it got pretty far, but did not produce LTSS and managed care. I think there's a lot of considerations in looking at that, moving people into a medical model versus a person-centered model. How would we, that's the basis of all of our services, right? Not necessarily from a medical perspective or an insurance perspective, what makes sense. So I think, how do we balance the preservation of our system as home and community based, as person centered, versus being managed by, a larger insurer? I think that would be something that we would need technical assistance or consulting on, from states or partners that have done it before, that have moved into managed care. I think it's a bit beyond and above what our capacity is to look at all the risks and benefits of doing that, not just, looking at the cost savings, but looking at the impact on, the services that people receive. As of right now, it's very, person driven. So I would want to caution in making sure that we have a thoughtful plan that includes, stakeholder provider input as to how would it affect, an individual receiving services, but also providers, being reimbursed for those services provided.
Yeah. So I always try to play a little bit of a devil's advocate with my questions. And so when I'm hearing this, my devil's advocacy question is, why would we do this? We have a system, it's working. What do we think the benefits of a change like this might be, and what has been offered back is that we initially had some estimates on the number of people that we thought would take advantage of CFI. We've not been hitting those numbers. And so as we've talked and agreed upon before, there's not only a cost savings, but a quality of life benefit for people who don't need to go into nursing homes and can stay at home longer. So between the financial and personal, if we found a way to drive up the number of people in CFIs and reduce the number of people in county homes, that could provide for significant quality of life improvements while saving considerable money. And the belief is that the MCOs, if they had the accountability for those long-term dollars, then they would have more of an incentive to aggressively manage that program. So that's the answer to my why would we do this question. And I just leave that out for you, not for comment, but for context.
Thank you.
So it's pretty much noon. Are there any, you're thinking, do you have questions or comments on this topic?
I'm sure I will.
I know you
I
will.
wasn't expecting the conversation.
Right, Representative, well, and I wanted to make it part of the conversation to tee up a real conversation. So Representative Wallner. Okay, well, I don't know how we did it, but it's noon, and I'm going to adjourn this work session. So thank you very much.